Welcome to this Step 3 review on anemia management, brought to you by Roadmap to Residency. Anemia questions on Step 3 are rarely about naming a disease. They reward the doctor who reads the numbers, decides on the next best step, and treats the patient in the most appropriate and cost-effective way. Today we will focus on 4 high-yield areas: iron deficiency treatment, vitamin B12 and folate deficiency, when to refer to hematology, and transfusion thresholds. Our goal is not to reteach all of hematology. It is to show you how these question stems are built and how to attack them. Keep your favorite question bank and a trusted review resource open alongside this video, because these patterns lock in only when you drill many practice questions. Let us get started. Here is what we are going to cover today. First, how to read an iron deficiency stem and pick the right treatment and the right route of iron. Second, how to separate vitamin B12 deficiency from folate deficiency, since the exam loves to test the subtle differences between them. Third, how to recognize the specific triggers that tell you to refer to hematology, and how to reason through transfusion thresholds when the stem hands you a hemoglobin number. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have the baseline content from your review resources. We are here to sharpen how you take the test. Our first strategy is to let the laboratory numbers point the way before you get lost in the story. Start with the last line of the question, since that sentence tells you whether you are hunting for a cause, a test, or a treatment. Then anchor on the cell size. The mean corpuscular volume is your first fork in the road. A small cell anemia steers you toward iron deficiency, while a large cell anemia steers you toward vitamin B12 or folate deficiency. Let the cell size narrow the field before you even read the options. For the fine detail of how each index behaves, lean on the anemia chapter of your review resource and your question bank explanations. Strategy 2 is to treat the cause and then confirm the cure, because iron deficiency questions punish tunnel vision. First, find and fix the source. Iron deficiency is a clue, not the end of the story. In an older adult, or in anyone without an obvious reason like heavy menstrual bleeding, the exam wants you to evaluate the gastrointestinal tract for occult bleeding. Be suspicious of any answer that just starts iron when the stem is hinting at an unexplained source of blood loss. Second, replete and then recheck. Oral iron is first line for most stable outpatients, and the exam rewards continuing it for several months after the hemoglobin normalizes, so the body stores refill. Save intravenous iron for patients who cannot tolerate or absorb the oral form. For exact dosing, use your review resource and your question bank explanations. Let us name the traps that iron deficiency questions rely on. First, trust the iron studies pattern. The classic picture is a low ferritin, a low serum iron, and a high iron binding capacity, and ferritin is the single most useful value. A low ferritin essentially confirms iron deficiency, so commit to it and do not let a colorful social history talk you out of it. Second, do not forget the source. In an older man or a postmenopausal woman with new iron deficiency, the strongest answer often looks for bleeding in the gastrointestinal tract rather than simply handing out iron. Third, beware the wrong route trap. The writers love to offer intravenous iron or a transfusion for a stable patient who only needs oral iron and follow up. Match the route to the patient and choose the simplest effective therapy. Your question bank explanations show these traps again and again until they feel obvious. Let us work through our first practice question. And this one tests iron deficiency treatment. A 40-year-old woman comes to the clinic with several months of fatigue and heavy menstrual periods. She is comfortable and her vital signs are normal. Her hemoglobin is low, her mean corpuscular volume is low, her ferritin is low, and her iron binding capacity is high, which is the textbook pattern of iron deficiency. She has no gastrointestinal symptoms, and her stool test for hidden blood is negative. The question asks for the most appropriate next step. Notice that she is stable, that the cause of her losses is already obvious, and that her cell size and iron studies all agree. Read the 4 options carefully, pick your answer, and we will reason through each one together on the next slide. Let us break this down. First, spot the pattern. We have a stable young woman with a low cell size, a low ferritin, and a high iron binding capacity, the textbook fingerprint of iron deficiency. Her heavy menstrual periods are the obvious source, and her negative stool test makes a gastrointestinal bleed unlikely. Second, apply the rule. When the source is known and the patient is comfortable, the right move is oral iron plus treating the blood loss, so option A fixes both the anemia and its cause. Third, eliminate the wrong answers. Transfusing 2 units is overkill for a stable patient and is the classic wrong route trap. A bone marrow biopsy and referral are far too aggressive when the cause is already in the stem. Intravenous iron is unnecessary when she can take iron by mouth. The correct answer is to start oral iron and treat the heavy menstrual bleeding. Here is our second practice question, and it is built to separate vitamin B12 deficiency from folate deficiency. A 70-year-old man comes to the clinic with fatigue, tingling in both feet, and an unsteady gait. His hemoglobin is low and his mean corpuscular volume is high, so this is a large cell anemia. His smear shows large red cells and neutrophils with extra segments, which is the picture the exam uses for a vitamin deficiency. His diet is poor and he takes a medication that lowers stomach acid. The question asks for the most likely deficiency. The single most important clue here is the neurologic symptoms, so hold that thought as you read the options. Pick your answer and we will reason through it on the next slide. Let us work through this answer. First, follow the nerves. Both vitamin B12 and folate deficiency produce a large cell anemia with extra segmented neutrophils, so the blood counts by themselves cannot separate them. The tiebreaker is the nervous system. Numbness, tingling, and an unsteady gait point specifically to vitamin B12 deficiency, because folate deficiency does not cause these neurologic findings. Now, why does vitamin B12 win here? The poor diet and the acid-lowering medication both fit reduced vitamin B12 absorption, which seals it. Iron deficiency is wrong because it causes a small cell anemia, not a large one. Folate deficiency is the tempting trap, but it does not explain the neurologic signs, and this distinction is exactly what the writers are testing. Vitamin C deficiency gives a different clinical picture. The correct answer is vitamin B12 deficiency. When a large cell anemia comes with neurologic symptoms, let the nerves make the call. Let us make transfusion thresholds simple, because this is one of the most testable numbers in anemia management. First, anchor on the restrictive threshold. For most stable hospitalized adults, the exam favors transfusing when the hemoglobin falls to about 7 grams per deciliter. That number is your safe default, and an answer that transfuses a stable patient at a higher hemoglobin is usually the trap. Second, adjust for the cardiac patient. The common exception is active cardiac disease, where a slightly higher threshold near 8 grams per deciliter is often used. And always watch for active bleeding with unstable vital signs, where you resuscitate based on the whole picture rather than a single value. For the precise cutoffs, confirm the details in your review resource and your question bank explanations. Here is our third practice question, and it tests transfusion thresholds. A 65-year-old woman is admitted with pneumonia and is improving on antibiotics. She has no chest pain and no active bleeding, and her heart history is unremarkable. Her hemoglobin is 8.1 grams per deciliter and stable. Her vital signs are normal, and she is comfortable. The question asks for the most appropriate next step. The key detail is that she is stable, has no cardiac disease, and is not actively bleeding. So compare her hemoglobin against the restrictive threshold before you choose. Pick your answer, and we will reason through every option on the next slide. Let us break down this answer. First, the restrictive rule. This patient is stable, comfortable, and not bleeding. She has no cardiac disease, and her hemoglobin of 8.1 sits above the restrictive threshold of about 7 grams per deciliter. Under a restrictive transfusion strategy, she does not need blood right now, so the best step is to observe and recheck the hemoglobin. Now, the key distinction between the wrong choices. Transfusing 1 unit or 2 units at a hemoglobin above the restrictive threshold is treating a number instead of the patient, and it is the overkill trap the writers plant in almost every transfusion question. A bone marrow biopsy is far too aggressive for stable anemia with no alarming features. Every distractor does too much. The correct answer is to observe and recheck the hemoglobin without transfusing. When the patient is stable and above the threshold, the disciplined answer is to wait. Here is a high-yield pearl that ties the referral theme together. The exam signals a hematology referral only when the picture goes beyond a simple deficiency. Watch for very low counts across all 3 cell lines, blasts or other abnormal cells on the smear, a suspected blood cancer, hemolysis without a clear cause, or an anemia that fails to respond to correct treatment. Those are the stems where a bone marrow evaluation becomes the right next step. On the other side, do not refer a straightforward iron, vitamin B12, or folate deficiency that you can diagnose and treat yourself. Referral in those stems is the classic overkill trap. When the cause is clear and the treatment is simple, the correct answer keeps the patient with you and starts therapy. Your question bank explanations are full of these contrasts, so study them side by side. That wraps up our review of anemia management for Step 3. Remember the core ideas. Let the numbers point the way, using cell size and iron studies to sort the anemia before you read the options. For iron deficiency, treat with oral iron and find the source. For a large cell anemia, let the nervous system separate vitamin B12 from folate deficiency. Refer to hematology only for the red flag stems, and anchor every transfusion question on the restrictive threshold of about 7 grams per deciliter, moving to about 8 in active cardiac disease. The best way to lock this in is to drill anemia questions under timed conditions and read every explanation. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe so you do not miss our next session. Good luck on your exam, and we will see you in the next video.